these lectures are being recorded. So you can find these lectures on my YouTube channel also. I'll try and upload and keep you updated there. So the name of the channel, I think you can find it. I'll try and update most of the lectures. Dent Drill. Okay, this is the YouTube channel. Not super active there, but I'll try and update most of my lectures there. Okay, but that doesn't account you for not attending my lectures. Okay. Okay, let's begin the lecture. So today's topic is dentin hypersensitivity. So in the past, or as kids when you were in first year and second year, you've heard and you've read a lot about the anatomy of the pulp, the histology of dentin, enamel, pulp. So you have to get that knowledge today and use it in whatever I'm trying to teach you today. It's a one hour lecture and I'll have to complete the lecture. So I'll be focusing on the most important things, right? Okay. Just get your note copy in handy. Okay. So the outline of my class will be definition, etiopathogenesis, lesion localization, lesion initiation, which are part of the etiopath, diagnosis, and a definitive diagnosis in that, investigations that you have to rule out before you can actually label it as dentin hypersensitivity, the management of dentin hypersensitivity, and lastly, the take-home message. So before we switch to the theoretical aspect of this unit, let's quickly watch this video so that you exactly know what we will be talking about in today's lecture. Okay, since I'm connected to my AirPods, somebody has to confirm. Okay, I'm not, maybe. Somebody has to confirm if it is audible, the video or not, okay? Is it audible? The video?
No, ma'am.
No,
And I'll put off my headphones. Let's go. Now it must be.
Tooth sensitivity causes significant pain and often impacts daily activities such as eating, drinking, and brushing your teeth. Sensitivity occurs when the dentin, a porous tissue in your teeth, becomes exposed. The dentin has microscopic channels called tubules, which are pathways to the nerve. Dentinal tubules are exposed due to receding gum tissue or enamel loss. Nerves are more easily triggered by certain stimuli, causing tooth sensitivity. Causes include brushing too hard, sugary and acidic foods and drinks, teeth grinding, dental treatments, and whitening treatments. If you are exhibiting...
It was a short video just trying to let you know what we're talking about basically today. I want you to take down this definition. If you ever see a question in your third year, final year, or as a postgrad resident, or in future anywhere you would like to apply, and a definition is asked, you're supposed to write exactly this definition. Please jot this down. Dentin hypersensitivity is characterized by short, sharp pain arising from exposed dentin in response to stimuli. Typically, now this is very important. One is thermal, second is evaporative, third is tactile, fourth is osmotic or chemical, and which cannot be ascribed to any other dental defect or pathology. This definition was given at International Workshop on Dentin Hypersensitivity. Please write this definition exactly the way it is, characterized by short, sharp pain arising from exposed dentin in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other dental defect or pathology. Now, this definition is very well described and it can actually differentiate with the definition of pain, right? So, you can be asked in your vivas in third year as well as final year between the difference between the definition of pain and sensitivity, right? Let's move on. The epidemiology of dentin hypersensitivity. It occurs in by the age group 30 to 40-year-old or more, prevalent of getting dentin hypersensitivity. Canines and premolars, they have more sensitivity as compared to other dentition. Female predominance is predilection or predominance is seen, which is because one of the reasons of dentin hypersensitivity is the wrong brushing technique, right? So females, as they're more concerned about their aesthetics, maybe because of their wrong brushing techniques, but it is hypersensitivity or dentine sensitivity is seen more commonly in females as compared to males. Let's quickly brush the anatomic considerations. I'm not going to be going into much detail. As you can correlate with the diagram on the left, you have read about the considerations in your juvenile years, first and second years. As you all know, dentine is considered as a vital tissue. जहाँ पे मैं रुक के बोलूँ that you have to write down, please write down. Otherwise, you just have to listen to what I'm saying, right? So dentine, as you know, is considered as a vital tissue and has the capacity to respond to physiologic as well as pathologic stimuli. And as it is known, dentine is covered by enamel in the crown surface and by a thin layer of cementum on the root surface. Nothing new there, right? So dentine itself is a sensitive tissue to stimuli due to the lesion extension of odontoblastic process and formation of dentine pulp complex, right? Dentine has very minute tubules, which are known as the dentinal tubules, which are filled with odontoblastic process. As you can see on the left, the odontoblasts, right? The processes are also surrounded by dentinal fluid, which the dentinal fluid, which form about 22% of the total volume of dentine. The fluid is completely filtrated and originates from the blood vessels of the pulp, right? This is not the most important aspect of this topic, but what is in the next slide. The neurovascular supply, where I'll be talking about nerve plexus of Rashko. You also read this in the past, so I'm gonna quickly brush you through that. So the crux of this slide is only that the plexus of Rashko, right? These nerves, they enter the tooth through apical foramen, as you can see, as apical foramen as myelinated nerve bundles, right? They branch to form subodontoblastic nerve plexus of Rashko. So what I'm trying to say here is that nerve fibers, they branch extensively beneath the cell-free zone. Now, when I'm talking about cell-free zone, you should quickly make this picture in your head. This is nothing new. You've all made this diagram in your exam, written exams. We've asked you back in second year, first year. So nothing new there. All I'm trying to say, right, in the root, no such plexus of Rashko is found, right? But it is majorly found in the pulp horn. And where is the pulp horn? Pulp horn is present coronally, as I've written here. No plexus is found in the root, but plexus of Rashko is found in the coronal part of the tooth, right? So we will come back to this topic when we talk about the theories of dentine hypersensitivity, right? So this is just a quick introduction to where exactly are we focusing today, right? If you want, you can just jot down the name of the heading. That's good enough, right? In dentinal tubules, my idea of getting this slide to you is just that there are two kinds of major fibers in the dentinal tubules, which are the A fibers and the C fibers. But when we talk about dentinal hypersensitivity or just sensitivity, they're both synonymous. The major fibers that are responsible for such kind of sensation are A fibers, A delta fibers. Please write this down, or you can quickly draw the diagrams delineating that the A fibers are on the coronal aspect and the C fibers are present apically. Right? A fibers are myelinated, responsible for sensation of dentinal hypersensitivity, which are perceived as pain in response to any kind of stimuli. C fibers are unmyelinated, and as I'm trying to show you here, the location is most important for A fibers. So if ever they ask you in the Viva, what fibers are responsible for sensitivity, don't think that they asked you beyond your scope. No. Okay. So etiopath or etiopathogenesis of dentine hypersensitivity. Now these are the things that you absolutely have to write in your exam and have to remember from today till I think whenever you decide is the last day of you practicing dentistry. As you can see the diagram I'm trying to show you, very beautiful dentinal tubules trying to show you exposed dentinal tubules as well. Let's talk about two things. We're going to be talking about, one is lesion localization, the other is lesion initiation. I repeat, etiology is divided into two aspects. One is lesion localization and the other is lesion initiation. So you have to write exactly like this in your exam. Lesion localization means the exposure of dentine. Hua kaise? How is the dentine exposed? There has to have variety of reasons causing the exposure of dentine. In lesion initiation, we'll be talking about three major theories of dentin hypersensitivity. Right? Why I'm trying to brush up this quickly? Because ye sab kahin na kahin you've read, right? Maybe you were not able to relate it that better because you were in the initial days of your dentistry. So let's talk about lesion localization. How is exposure of dentin happening, right? So the first reason, attrition or bruxism. You've all seen cases like these in your case history, clinical hours. Attrition, how attrition looks like: erosion, abfraction, aberration. These are non-carious lesions, right? You will also get questions on non-carious lesions. When they talk about non-carious lesions, this is exactly what you have to describe: attrition, erosion, abrasion, abfraction. These particular terms have their definite definitions. So you'll have to remember those in that aspect of the unit. I will not be covering the definitions of attrition, erosion, and etc. today. But assuming that you know what is the difference between all of these, pocket reduction surgery. If the tooth has a pocket which is deep enough and requires a surgery, in such cases also you can end up with, iatrogenic exposure of the dentine. Tooth preparation can cause exposure of the dentine. Excessive flossing or wrong brushing technique can cause exposure of the dentine. Any periodontal disease which has become chronic can cause exposure of the dentine. Next, most important that everybody has read, maybe does not remember by now, you can quickly draw this diagram. Very good diagram, important for you to draw in the exam as well. Lesion initiation. वो तो बात हो गई lesion localization. Where exactly is the lesion localized of that hypersensitive area? Where exactly is this area? In lesion initiation, what is causing this hypersensitivity? Right? Actual mechanisms are based on the theories of dentin hypersensitivity. Let me tell you, not all the theories are widely accepted. Okay, when I describe the three theories, you will know exactly which theory is the most accepted theory. Maybe some of you sitting today already know which is the accepted theory. Can anyone quickly tell me which is the most accepted theory? Quickly, quickly, quickly.
The hydrodynamic theory.
Who was that?
The Mansi Sen.
Good, good, good. You're listening. That's good. Thank you for answering. So lesion initiation, actual mechanism. Let's talk about the three theories quickly. Direct nerve innervation, odontoblastic receptor theory, hydrodynamic theory. Let's look at this beautiful diagram on the left, and very briefly in a summation, they have told you exactly what these theories are. The first one is the neural theory, or as the name suggests, direct nerve innervation. If you don't remember the name, just remember एक तो है जिसमें nerve है, एक है जिसमें odontoblast है, और third जो है उसमें fluid है, odontoblastic fluid, and it will get very easy for you to remember. One is neural मतलब nerve, second is odontoblast मतलब odontoblastic receptor या tubule, odontoblast खुद ही involve हो गया, and third is the hydrodynamic. If you don't remember the name of the most accepted theory, then you just remember the fluid wala theory, right? The movement of the fluid wala theory. The first one is dentine is innervated directly, as in they're trying to say कि dentine के अंदर nerve fibers and that will cause the sensation and will eventually lead to sensitivity. Second one is odontoblast can act as a receptor itself, also known as transduction theory. People who would like to remember all 2-3 names of these individual theories, that is amazing for you. If you're able to remember, please do remember. If not, don't worry about it. All you really need to know is the difference between the three theories and you're sorted. The third one and the most accepted one is receptors are in the pulp and are stimulated by fluid movement through the tubules, also known as hydrodynamic, most accepted. All these remineralizing agents, all these desensitizing agents, they are all based on this theory. Am I clear? The diagram beautifully describes. You just have to draw the same diagram every time. Just have to know exactly मुझे दिखाना क्या है, right? Let's move on. The first one quickly, the direct nerve innervation or the neural theory. So they're trying to say nerve is the primary receptor and it excites the action potential. Nothing new there. But this theory did not work well, Q, because they suggested that the dentine is also innervated directly by the nerve endings. Not widely accepted. Why? Because when local anesthesia हम apply करते हैं, it does not abolish the sensitivity. When we're using topical anesthesia or local anesthesia or anesthetics in any form, it does not relieve the sensitivity. Why is this happening? That only means the dentine is not innervated by the nerve. It does not have any neural receptor, right? And also it is not accepted because newly erupted teeth, they are also sensitive even when the plexus or the intratubular nerve is not even established, right? Nerve तो है ही नहीं वहाँ पे, then how come newly erupted teeth are feeling sensitive? So that on those basis, this theory was not accepted. So the question that was, around this theory was, is the outer layer of dentin directly innervated? So that was one question which was not answered well. So this theory was not accepted. Next is odontoblastic receptor theory, or what is the name? Transduction theory. Whatever names you remember, all you need to know is the difference between the three theories. Next is odontoblastic receptor theory. They're trying to say कि जो odontoblast है, it has the same neural crest origin as the nerve. Hence, it has the ability to transduce and propagate impulses. Hence, the name transduction theory. But it is not true so, because but no junction between an axon and odontoblast actually ever existed. So this theory was thrown away. Membrane potential of odontoblast is also very low to permit this transduction. So it has variety of reasons to put this theory away, and that is why this theory is not accepted. A good diagram you can draw in your exam, that odontoblast is acting as a receptor. So you just have to show what the theory is about. So you can actually use your imagination and draw a nerve, and odontoblast acting as a nerve inside the tooth. You can do all that, okay? It's not that you have to stick to the exact diagram. As long as you understand the concept, that's okay. Next, and the most accepted theory is the hydrodynamic theory. Very, very important. If you're writing, please write down. The fluid movement within the tubule, it distorts the pulpal environment. Why do we still accept this theory and most accepted theory? Because this fluid movement, it will distort the pulpal environment. And this pulpal environment is sensed by free nerve endings of the plexus. If we have wider tubules, there is increased fluid movement. And when we say wider tubules, the wider tubules are present at the coronal aspect, right? At the coronal aspect of the tooth, and that's where exactly the sensitivity and pain is felt. Profuse branching of the tubules is present at the DEJ, which explains the increased sensitivity to the patient, right? It has all the right answers to support this theory. And as I told you in the beginning only, the idea of me showing you the fibers was this only, that A fibers are present in the coronal aspect, and therefore response of A delta fibers, its response depends on the pressure, the intensity of the stimuli. So what fibers get activated because of the fluid movement? It is the A delta fibers. These are all small viva questions. Don't miss out on anything. So stimuli you already know can be anything: cooling, drying, evaporation, application of hypertonic chemicals or acids. As you can see on the diagram in the left, you can actually draw this diagram. The fluid travels through the tubule and excites the nerve which is present inside of it. The stimuli on exposed dentine causes fluid movement in the tubule. So that is why when you come to the clinics, when you do your first case, and if ever any staff watches you blow dry the tooth with the three-way syringe, not water, but you blow the air out of it on a vital tooth, obviously we will be giving you vital tooth only, where we ask you to do a restoration. And what you do, instead of isolating with cotton rolls, you blow it extremely with that three-way syringe, and you blow that air onto the tooth, onto your cavity. Now just imagine what you're doing. You're actually collapsing the dentinal tubules. Because of you blow drying the cavity, the odontoblast is collapsing. Don't you think it will activate the A delta fibers and eventually cause super high sensitivity to the patient. Justified, and that is why if I ever see any student blow drying a vital tooth, I am super angry, because more than any good to the patient, more than giving that restoration to the patient, you're giving him lifelong sensitivity. So never blow dry a tooth. ये बांध लो. This is like you make a promise with yourself that if you're using a three-way syringe, you're not supposed to use the air from that three-way syringe. You can use the water as and when you want, but do not touch that air. Blowing that air is actually contraindicated in most of the cases of dental restoration. Okay, let's quickly summarize the three theories. I hope you understood. The first one was neural theory. It says that direct stimulation of nerve terminals is causing the sensitivity. The second one was odontoblastic theory. Over here, it's showing us the third one, that odontoblasts can also act as receptors, and this is also known as transduction theory, but it is also not true. The center one is the most accepted one, is known as the hydrodynamic theory. What is causing the sensitivity? It is the movement of dentinal tubules. Basically, the best example for this is you blow drying the dentine, collapses the odontoblast, exposes the dentinal tubules, and causes the movement of the fluid, which actually eventually activates the A delta fibers and causes the sensitivity and the pain. So, dentin hypersensitivity, if people don't understand, is a complex subject in itself, because, okay, why I say so is because it is confused with a lot of other conditions of dentistry, right? So, like any other clinical condition, an accurate diagnosis is most important before starting the management of dentin hypersensitivity. As I just mentioned, it has features similar to other conditions like caries, like fracture, like chipped enamel, like reversible pulpitis, or maybe periodontitis, or other procedures like bleaching. So, right? Let's talk about, we'll come back to this one again. Let's talk about how to differentiate or how to diagnose one condition from another, or maybe a lot of conditions from how to delineate, acha, ye to sensitivity hi hai. How do you do that? So I'm going to give you a few examples, like if we have a pressure on tapping the tooth or percussing the tooth, right? Or if the tooth is tender, then you should know that there is some periodontal involvement, or maybe it is pulpitis, so that you can rule out between sensitivity and where exactly the pulp is inflamed. Or if the patient is biting on a stick, as you can patient is biting on a stick, as you can see the image on the right, then you should know. And if the pain occurs on biting on that stick, you should know this pain is occurring because of fracture. Slowly, gradually, when we introduce you to subjects like fracture and all these things, you will know exactly what all diagnosis and how to differentiate between the diagnosis, right? We can go for a trans-illuminating dye to detect the fracture line also. So what we have to, how do we differentiate between the diagnosis? You have to know whether it is a cracked tooth syndrome, whether it is a fracture, is it a traumatic occlusion, is it a chipped teeth, is it only dental caries, root caries, post-operative sensitivity after any restoration, if there is a marginal leakage that you can spot with your dyes, then if there is pulpitis or maybe a periodontal cause is there, vital bleaching procedures can also eventually cause high sensitivity to the patients, right? So all these factors have to be ruled out before you even start managing hypersensitivity. Because 99% of the times, if you take care of the major cause of the tooth, the offending tooth, if you've dealt with the caries, if you've dealt with the leakage, pulpitis, pain, fracture, then 99% of the times the sensitivity is taken care of, right? So you don't directly have to jump कि पहले तो मैं sensitivity का इलाज करूंगा या करूंगी, उसके बाद I'll come back to caries. No, that's not how it's done. In investigations, we have a lot of techniques to investigate. As I'm mentioning a few: air jet, cold water jet, electrical device, dental explorer, periodontal probe, radiographs, caries diagnostic devices, percussion testing, occlusal assessment, bite stress test. As I'm showing you pictures of few right on the right side, you can see there is air jet flow, there is cold water jet, electrical devices. As you can see, I'm showing you a radiograph with absolute atresion, severe atresion on the lower anteriors. All these are things for you to investigate and come to a conclusion or make a definitive diagnosis. So when I say air jet, if you're actually trying to diagnose hypersensitivity, then use of air jet is okay. But if you're not, if the patient is not even having sensitivity, then your air jet will absolutely cause him sensitivity. So you should know exactly when to go for an air jet. So definitive diagnosis can be established by a jet of air or using exploratory probe on exposed dentine in mesiodistal direction. Please write this down. This is an important Viva question. How do you definitively diagnose hypersensitivity? Don't give them absurd answers. Write this one. I'm showing you how the exposed dentinal tubules look in the SEM section, which is the scanning electron microscopic section. If you look at the dentine, this is how your dentine will look like with exposed dentinal tubules. And how you can expose if the patient is complaining of sensitivity and you're not able to rule out कौन सा tooth है, कौन सी जगह है, कौन सा aspect है, then you can go land up to a definitive diagnosis by using a jet of air or using an explorer probe on exposed dentine. Since the tooth is absolutely vital, the patient will immediately react to it. Quickly, let's discuss the most important aspect of today's class is the management of dentine hypersensitivity. Since as third year students, I could have made a lecture which was very basic and very, what do I say, something that even a first year student would know, right? But instead of that, I've got you a little, little modern advancement in the management of dentine hypersensitivity. And what makes me do so is because if tomorrow your relative asks you what is the difference between Sensodyne and a Colgate toothpaste, or what exactly, what do you recommend for me? I have severe sensitivity on having cold, having an ice cream. What should I think of? What should I be taking? And you in your head, being a third year student, will be going to final year anytime soon and will be a graduate after that. You don't even know what is the difference between the two kind of products, and you're like, ठीक है, same ही होंगे. I'll look into the ingredients and I'll let you know. And in your head, you feel like a dumb person, and you're like, I don't know the difference. And I can tell you, all the students sitting here don't know the difference, right? That is why that makes me do a little bit for you today. As you can see the image on the right, moving on, the management of dentine hypersensitivity. Please draw this diagram, very important. The management, किसी भी type का management हो, it is based on two aspects. Whatever products that you have on your Amazon, eBay, your stores, whatever XYZ products are available to cure sensitivity, or they telling you it will short cure your sensitivity in 3 weeks, 2 weeks, whatever. They're based on the concept of these two. The first concept is to occlude or to plug the dentinal tubules. To plug the dentinal tubules. As you can see in the diagram A, you can see some kind of product or some kind of salt which is potassium based is placed on the tubule, and it has absolutely blocked the tubule. As we go back to this diagram, and if you apply a product which will absolutely block or plug the tubule, the patient will not complain of sensitivity. Because why? There will be no movement of the fluid from inside to outside, right? So the nerve will not be stimulated, your A delta fibers will not be stimulated, hence zero sensitivity. So what's important is to occlude or to plug or to block these dentinal tubules. So first basis of these product designing is based on occluding or plugging the dentinal tubule. You have to draw this diagram also, right? पहले एक nerve बना दिया, फिर pulp बना दिया, फिर odontoblast बना दिया, उसको plug कर दिया किसी product से जो potassium based है, right? Second is by nerve desensitizers. तुमने directly nerve को ही desensitize कर दिया, right? There are other kinds of materials like adhesive materials that will actually desensitize the nerve itself. As you can see, जैसे nerve desensitized hui, your odontoblastic tubules are also blocked, as you can see on that B image. Let's quickly move on to more elaborated form of this management. So let's just please write this down. The reason I'm starting this at 9:35 only is because I want to take time on the management. The first one is classification of products. Now we describe कि ये जो products बन रहे हैं, all the R&D going behind these products is based on two concepts. One is कि या तो plug को जो odontoblastic tubules है, जो dentinal tubules है, उसको plug ही कर दो, उसको block कर दो. And the second concept is nerve desensitized कर दो. Only two concepts are there, right? So what is the classification? How do we classify the variety of the numerous products available in the market? By three aspects. The first is mode of administration. The second is mode of action. The third is others. Please write this down exactly the way it is shown in your slide. The first is mode of administration. Some people try to get the products at home, like your toothpaste only, or some people will go in the office at the clinic and get rid of the sensitivity by any adhesive restoration. The second is mode of action. That only at home and in office depends on the severity of your sensitivity. The second one is mode of action. As I told you, two aspects of this mode of action was, the most important one was plug tubules or occlude the dentinal tubules. The second was nerve desensitization. The third is protein precipitation. The fourth is dentine adhesive sealers. The next is lasers. And lastly, homeopathic medication. The third is others, which includes the gingival graft, very predominantly used in periodontics as perioglass, periodontal graft, bone graft, etc. Right? Don't have to go into the detail. Let's quickly move on to the most important aspects of management. Basis of mechanism of action. The first, just a second. I'm getting. Am I audible? Because I had a call, it might have gone unstable, my network. Am I audible? Please say yes.
Yes, ma'am.
Thank you. Let's move on. So here I was, classification of products, mode of admin, mode of action, and others. I hope you've written them down. Basis of mechanism. So one thing I'd like to tell you, everything written on the slides has to be copied the way it is, but you don't have to worry to elaborate these products, right? At your level as a third year student, if you remember the names of these products, that is amazing for you. At least you know कि potassium nitrate जो है वो nerve desensitize करता है, glutaraldehyde जो है या फिर gluma desensitizer very widely used, वो क्या करता है, protein precipitate बनाता है और फिर occlude करता है. So these are important things that you should write down in your exam. Don't have to worry about the in-depth mechanism of these products, right? Basis of mechanism of action, as I told you, nerve desensitization, potassium nitrate. The second one is protein precipitation by glutaraldehyde, silver nitrate, zinc chloride, strontium chloride, hexahydrate. Please write down exactly like it is. Let me clarify the chapter to you in my subsequent slides. Moving on, since we're talking about potassium nitrate and potassium salts so much, let me just quickly tell you ये करता क्या. कोई भी type का potassium salt हम लेते हैं, what it does is it moves along the tubules, it moves along the dentinal tubules through blocking the axonic action. Axonic action किसका होगा? Obviously that intradental nerve fiber, right? And decreases the excitability of the tooth, right? It moves along the dentinal tubules and blocks the axonic action of the nerve fibers itself and reduces the excitability of the tooth. Next we have, let's just quickly watch a video on glutaraldehyde, or also known as gluma desensitizer. can write the name also. क्या करता हूँ? It penetrates the exposed dentinal tubule. Vital test and the restorations, right? Third one was plugging dentinal tubules. Now you see a lot of variety of Sensodyne available in the market, naming rapid relief, based on cavity prevention, a lot protect and repair, all these things. So plugging dentinal tubules, like what all substances or products that are used in these kind of toothpaste? For example, strontium acetate, please start writing plugging dentinal tubules. Strontium acetate, sodium fluoride, stannous fluoride, potassium oxalate, calcium phosphate, calcium. Somebody said something?
Ma'am, your voice is not very clear.
Let me just confirm if it is clear now. Am I audible clearly now?
Yes, ma'am.
Sure? Yeah? Hello?
Yes, ma'am.
Okay. Let's move on to plugging dentinal tubules. Please start writing the what all materials are used in our toothpaste. Strontium acetate, sodium fluoride, stannous fluoride, potassium oxalate, calcium phosphate, calcium carbonate, and bioactive glass. So let's quickly describe fluoride because fluoride is used in n number of toothpaste today. Fluoride, what it does is it precipitates calcium fluoride crystals inside the dentinal tubule. I repeat, what it forms calcium fluoride. Tooth के अंदर calcium है, fluoride हमने ऊपर से डाल दिया. So what does it form? It forms calcium fluoride crystals in the dentinal tubules, and thus it reduces the dentine permeability. And since the permeability is reduced, so dentin becomes dentinal tubules are almost clogged, blocked, and insoluble. As you can see the image on the left one, ऊपर में देखो, the SEM section, the electronic microscope section shows you that the dentinal tubules are open. Then you occlude or plug these dentinal tubules by application of such toothpastes where you have fluoride, and the action is it forms calcium fluoride and reduces the permeability of these tubules and literally blocks the tubules, right? So open your heads when you're thinking about such things. Let's move on. Let's quickly watch a video on Sensodyne so you know exactly हम क्या prescribe कर रहे हैं और क्यों prescribe कर रहे हैं अपने relatives को.
When enamel wears down or your gums recede, microscopic holes in dentin, the inner layer of your tooth, may become exposed. This can make the nerves inside vulnerable to triggers, which may cause a short, sharp pain, known as sensitivity. Sensodyne Rapid Relief is engineered to beat sensitivity pain fast. It has a unique formulation with stannous fluoride that quickly creates a barrier over the sensitive areas of your teeth, so you can get proven pain.
Right? Since the class is only 1 hour, so I've only got you bits and pieces of these videos. If at all anybody would like to prepare from this lecture, you'd find this on my YouTube channel also. The next one is dentine adhesive sealers. You've heard a lot about fluoride varnishes, and when you get community dentistry in your final year, you'll read a lot about these varnishes, right? Fluoride varnishes. Even in conservative dentistry, we emphasize on varnishes. So basically, varnish karta kya hai? In dentistry, in conservative dentistry, we talk a lot about please define cavity varnish. In that, we have a copal varnish. What it does is used to cover the exposed dentine, although it has a short-term effect. So what you have to keep doing is reapplication of these varnishes. But when you move on to community dentistry, you will read about sodium fluoride, stannous fluoride as varnishes. Then we have GIC, you already know that. Composites, we give you cases like cervical abrasion, and we ask you to cover it with using GIC. So all these things are also used to treat the moderate to severe cases of sensitivity. Dentine bonding agents, right? HEMA is a material is used to create deep resin tags and block the odontoblastic tubules. Let's go quickly watch a video on varnish called Durafat, or this one is available as Durafat. Let's watch it.
5% sodium fluoride white varnish with tricalcium phosphate, TCP. More than a fluoride varnish, Vanish White Varnish with TCP contains fluoride along with a smart calcium and phosphate with a protective barrier that allows them to coexist with fluoride until the formula is applied. As the varnish comes in contact with saliva, the protective barrier surrounding the TCP breaks down, causing calcium and phosphate to be released with fluoride at the tooth surface. The unique patented formula of Vanish White Varnish allows the varnish to migrate to all tooth surfaces, including interproximal and lingual surfaces, so it delivers fluoride and calcium to tooth surfaces. The varnish stays in place, but saliva gradually wears it away from the surface, layer by layer over time. Each layer that is worn away exposes and releases more fluoride, calcium, and phosphate. It continues to release fluoride, calcium, and phosphate throughout the recommended treatment period, up to 24 hours. This fluoride treatment takes only seconds to apply. It's as simple as applying a thin layer over the recommended treatment areas. For larger surface areas, apply Vanish White Varnish in sweeping horizontal brush strokes across multiple teeth. Then, let the flow properties do the rest of the work, delivering fluoride, calcium, and phosphate to the important areas of each tooth. When patients need relief from hypersensitivity or can benefit from the combination of fluoride, calcium, and phosphate, choose Vanish 5% sodium fluoride white varnish.
So they've called it Vanish. Varnish है ये sodium fluoride की, and they've called it Vanish. Don't go by the product, but it is an interplay of calcium, phosphate, and fluoride. You're giving fluoride from outside. It combines with the saliva, so you have the saliva has a major role to play in remineralization. Let's talk about remineralization in my subsequent slides. Next method is by periodontal soft tissue grafting. As I just told you, the periodontal people, they use graft like periograft such as bone graft to cover the surgical sites so that the tooth is not exposed and does not cause sensitivity, right? As you can see that image of perioglass on the left, it's a bone graft material. Then we have anti-inflammatory agents like corticosteroids. 0.5% topical prednisolone can also be used. It's one of the methods to manage hypersensitivity. Next is crown placement and restorative materials. Obviously, the prostho people, if they're doing a crown preparation on a vital tooth, then they will cover the tooth so that the dentine is not exposed since it's a vital tooth and it will cause sensitivity. So you have to cover the tooth by placing a crown. Next we have is lasers. These are the variety of lasers available. Nd:YAG, erbium YAG, helium neon, all these lasers are available. Depends, like the laser, they're massively used in dentistry today, but it depends on the type of laser that you're using. Maybe it's a diode laser. Diode laser is the one which is used for hard tissue, right? So there are two kinds of lasers available. One is for soft tissue, gingiva, the other is for hard tissue, like the crown itself. And a lot of therapeutic parameters are used in dentistry for lasers, such as the length of the laser beam that you're using, the time at which or the time duration for which you're using the laser on the tooth, the intensity of your beam, etc. A lot of parameters have to be taken care of. You will learn more about lasers when you move to for final year, right? Quickly watch a video on diode laser. Little portion of the crown is exposed, So basically, you're using a fluoride gel, which is already gonna come in contact with saliva and lead to production of more calcium and phosphate that will cause remineralization and clog the dentinal tubules. But with the application of laser, you're trying to get this deep inside the dentinal tubules. How does this happen? Just watch the video. modifying and altering the dentine surface to penetrate your fluoride inside. Obviously, it makes all the sense. You can't just use the laser on the tooth like that. You need some kind of agent, some kind of desensitizing agent to go inside, plug the dentinal tubule. So lasers can be used as an adjunct to it with your desensitizers. Photobiomodulation is kind of an effect that is used by lasers. Photobiomodulation. Don't have to worry a lot about the new concepts that I'm sharing with you today. Only if you guys remember the names, that's gonna fetch you all the marks in your exam, and that will broaden your horizon on this unit, which is dentin hypersensitivity. So at your stage, most of the people will just write two methods. One is nerve desensitization, other is plugging, and you'll write 2-3 older products which were available. That's not how you think about at this time, right? Next is homeopathic medications like propolis. Last is iontophoresis. In this, we use a low galvanic current to accelerate ionic exchange. It precipitates insoluble calcium with fluoride gel to occlude. Just remember the name. I'll quickly show you the video on iontophoresis so you can just think about what the procedure is.
Covers it with a mineral solution and applies an electrical current too weak for the patient to feel. The deposited mineral quickly hardens, completely filling the cavity. Researchers say this method could be especially useful for children.
So when you talk about iontophoresis, you should remember कि अच्छा एक current producing device है, उसके ऊपर से we are applying a desensitizer. What we're doing is the aim is कि इस current flow के साथ हम फटाफट से अपना desensitizer उस tooth के अंदर डाल दें. This will not even cause pain to the patient, and your procedure is done. So you're using using currents to get your desensitizers inside the tooth.
Children have a better experience of going to the dentist, so they haven't had the necessary drilling and injections for routine fillings. Then they'll be much more positive in later life and probably become much more regular patients.
Dentists point out that the new method is most efficient on early stage cavities, which makes regular dental checkups essential. The whole
right? So what you understand from most of the methods that I've taught you in my last few slides is, as long as the dentine sensitivity is mild to moderate, as long as the lesion or if it is not converted into an abrasive lesion which requires a coverage or a restorative material to cover it, you can deal with a minor sensitivity issues with products that I've showed you in my last few slides. If it is a deep lesion and it is fully exposing the dentine, almost approaching the pulp, in those cases, you will have to go use adhesives and restorative materials. I hope I'm making some sense here. Next, quickly, let's discuss the desensitizing agent properties given by Grossman. As you've already seen in the videos, it should act rapidly with long-term effect. It should be non-irritating to the pulp. It should be painless, should be easy to apply, and definitely should not stain the tooth. Current trends in the treatment, quickly write these now. Few of them I've already covered. Just write the names. Why I got this slide? Because when you're answering this question, the last slide should be on advancements. What are the dentists currently using? What all things are there in the market today? So just write the names, and I'm sure that you're going to fetch 100% marks. Arginine based products. The name of the product is Pro Arginine. Even in India, we've got Colgate Sensitive Pro Relief, which is based on arginine. You didn't know till now, but this Colgate Sensitive is based on arginine. Just write the name. Lasers, I just showed you the video, how diode laser is used to manipulate and deliver fluoride inside the tooth. Bioglass is again based on the periodontal graft, right? You provide a bone graft inside the tooth. Casein phosphopeptide, just write this, the name CPP. I'll show you a video. As you can see, the right bottom, GC tooth mousse. You Google it on Amazon, or you just write Amazon pe GC tooth mousse, and you can just buy the product and use it. You yourself will see how many non-dental people use this today, and you might not even be knowing the name of this product. Right? GC tooth mousse. It's based on CPP, ACP. Now CPP, I've already written casein phosphopeptide. Casein phosphopeptide, and ACP is amorphous amorphous calcium phosphate. So this GC tooth mousse is based on the application of casein phosphopeptide and amorphous calcium phosphate. You just have to remember that there is an interplay of CPP and ACP when you apply tooth mousse, and it is really, really helpful in remineralizing early lesions, early carious lesions. If you see your own tooth or your any of your relatives and you tell them कि लगता है caries initiate हो गई है, right? Cavitation नहीं हुआ है, but I can tell you that caries has initiated. In such cases, you can refer or you can prescribe them tooth mousse. So in cases like these, GC tooth mousse, which is based on CPP and ACP, casein phosphopeptide and amorphous calcium phosphate. Nanodentistry, a lot about nanodentistry is being done and said. It's based on nanorobotics, right? So these are the current trends in dentistry, in treatment of dentin hypersensitivity. Let's quickly watch a video on GC tooth mousse.
White spot lesions are common occurrences among many patients, especially children. White spot lesions start with the accumulation of plaque bacteria. The bacteria feast on sugars and release acids, which in turn attack the tooth enamel. The result is a shift in oral pH balance. This net loss of calcium and phosphate is called demineralization. Tooth mousse from GC America is a topical cream with Recaldent CPP ACP inside. When tooth mousse is applied to the tooth surface, the CPP-ACP, a complex of casein phosphopeptide and amorphous calcium phosphate, delivers bioavailable calcium and phosphate to the enamel instantaneously. The calcium and phosphate are infused into the enamel, and the result is the strengthening and widening of the enamel rods, a process called remineralization. Remineralization is a result of a net gain in calcium and phosphate. For optimal oral health, apply tooth mousse for 3 to 5 minutes twice a day.
Anybody who's got minor sensitivity, try using tooth mousse and let me know how you feel about it. So when, I don't know when you guys, whether or not I've taken a discussion in the department for a few of you on remineralization, and I told you if the lesion of, if the caries is not cavitation, is not frankly cavitated, right, then it is a remineralized carious lesion. It can be remineralized. The demineralization is not so much. If you apply desensitizing agents on such kind of caries, it can be remineralized. So on such cases, you can use products like that I just discussed, like GC tooth mousse. So remineralizing agents have some ideal requisites. What are these? Obviously, the first and foremost that you've seen in almost all the products is that whatever product you apply, it should be able to deliver calcium and phosphate. And this calcium and phosphate inside the subsurface will eventually react with saliva and actually enhance the remineralizing properties of saliva. It should not deliver excessive calcium. It should not favor calculus formation. It should work in an acidic pH because obviously demineralization happens there. So it should be able to work in xerostomia or dry mouth also. The agents, most of which I have already discussed, fluoride releasing toothpaste already done like Sensodyne and a wide variety of products available by Colgate and Sensodyne. CPP, ACP, I just discussed, casein phosphopeptide and amorphous calcium phosphate. Bioactive glass, the one we use in perio. Tricalcium phosphate, just quickly write down the name. It comes with the name Clean Pro Tooth Creme, as you can see. One is Enamelon on the left side, ACP technology. You just writing the names in your exams, the examiner will be thrilled to read your answers. Pro Arginine, I just told you, Colgate also has a Pro Relief, which is based on arginine technology. Nanodentistry, which has nanorobotics in place, right? So all these new advancements are already, have already been done in Dentin Hypersensitivity. All you need to know is write down in your exams. Just the name will fetch you good marks. So let's quickly do the conclusion and then do a recap of this unit. So as I mentioned in the beginning also, that dentin hypersensitivity is always a diagnosis of exclusion. इसका क्या मतलब है? What is the meaning of diagnosis of exclusion? मतलब first you have to exclude other conditions that are affecting the tooth, other conditions that are affecting the offending tooth before you can rule out and manage dentin hypersensitivity. In short, I'm trying to tell you, you have to eliminate any caries, you have to eliminate any fracture, you have to eliminate any bone loss, any periodontal issue which is affecting the tooth, and only by excluding criteria you can actually absolutely manage dentin hypersensitivity. स्पष्ट शब्दों में अगर मैं बोलूं तो इट मीन्स पहले बाकी सारा इलाज करो, dentin hypersensitivity will be taken care of by that only. If you've taken care of all the other conditions which the tooth is affected by, your dentin hypersensitivity is 90% dealt with already, right? Other conditions have been diagnostically eliminated. Least invasive, most cost effective treatment that you can actually prescribe to your relatives and your patients and your dear ones is use an effective desensitizing toothpaste that you already do, but you should know कौन सा क्या based है, कौन सा क्या mode of action है, right? So since it's already 10:01 and I think somebody must be in line for another class, and I hate to end the class. I wanted to go for a discussion, maybe a question answer session or something, but I'm just doing my bit and trying to get you the data so you can get hold of this presentation or any further. You can ask me questions in the comment section. You can mail me directly. I'm just giving 1 minute and just kindly unmute yourself. Any questions from your side, please throw them right away. Quickly. It's 10:02. Anyone, quickly. Everybody's asleep. Sabke cameras band hai. That's a shame. Shashti has got dog pictures in her DP and the dogs are also sleeping. Nice. Rohit, any questions, Rohit? सब समझ आ गया तुम्हें? तुम्हारी आवाज नहीं आ रही रोहित.
मैम आ गया थोड़ा बहुत.
थोड़ा बहुत आ गया. I know it's a different topic for a third year student, and let me tell you, the way I got you the lecture is not very easy also, right? I've introduced you with, like, I think hundreds of new things which you were not knowing before the class. So it's easy to confuse it with a lot of you must be overwhelmed with the data I've got you today, right? So one advice to you is just remember the names. I hope you've taken down the notes. Have you?
Yes, ma'am.
Everybody? Samiksha? Radhika?
Yes.
Okay.
Yes, ma'am.
Yes, ma'am.
Access the lecture. It's freely available on YouTube. You can go anytime. I'm going to be uploading by the end of this week or maybe tomorrow. Please go ahead, make your notes from the lecture. Any questions, mail me directly or write it in the, you can mail me directly or write me in the comment section. So it's freely available for you. Don't worry about that. And I'll try to post the previous lectures also if I have them in my, hard disk or so. So I'm gonna end the class because it's already time. Okay, I hope you understood the class. Did you? Mohit? Good morning.
Yes, ma'am.
Okay. So let me end the class. You guys have a good day. Take care of your family. Bye-bye.